Hi, I'm Sofiane El Djouzi, GI and bariatric surgeon from Chicago, and we're here in Baltimore, the beautiful city for SAGES 2019. As part of the Trailblazers, Foregut Surgery, I have a well-achieved guest, an educator, a teacher, and an innovator. I've had the chance to meet him in person a couple of occasions, and also I've watched his work throughout the years, and also had the chance to travel overseas and get trained by him very lately in Strasbourg with ERCAD. This is Professor Lee Swanstrom. Welcome.
Oh, Sofiane, thank you very much. Kind introduction.
Thank you. Dr. Swanstrom, if we go through your curriculum or your achievements through the years, that may take beyond the spectrum of this interview. I think one of the questions that I would call myself as qualify myself as a junior surgeon. What are the pros? What are the key components for success in this specific field of foregut surgery?
I think foregut surgery is a fairly unique aspect of surgery, digestive surgery in particular, in that it's reconstructive, kind of restoring normal physiology to patients. And because of that, it kind of demands from the surgeon to not be a simple technician, but to really understand the disease from the almost molecular, cellular level, all the way to kind of palliative treatment for incurable cancers. And that's fairly unique, certainly something like appendicitis or gallbladder disease. You would never have that spectrum of the disease that the surgeon is uniquely able to be responsible for.
Let's say that tomorrow I'm interested in setting up a foregut practice. What would be the key element for me, or the key elements to incorporate in a way that this is a successful practice?
Yeah, that's a great question, and certainly something that's very germane for all the fellows that we train. I think the keys are, as you're well aware, our medical colleagues are not all that familiar to some extent or friendly with surgical treatments of reflux disease, since there's pharmaceutical alternatives as well. So I personally think if you want to be a successful foregut specialist, you need to take over the diagnostic and physiologic testing part of it. I think if you find a practice that doesn't have a local motility lab, if you do your own endoscopy, then suddenly you really get those patients at the entry point and you can direct them to the right pathway, often medical, but sometimes surgical, and I think surgeons have more equipoise on choosing the right treatment pathway for their patient.
So from what you're telling me, it sounds like I need to keep my the GI physician as friends, but at the same time we need to be the front line in seeing those patients and being able to interpret all the studies that we do, like the pH, manometry. Is that what you're suggesting? Yeah,
absolutely. I think even if you're fortunate enough to have a good collaborative relationship with a strong GI group that does high quality motility, I think it's obligatory that the surgeon interpret, not just accept the computer readout or even the gastroenterologist readout, and interpret their own motility, their own pH studies, their own endoscopy and pathology reports. Medical people look at these things for different reasons. They look at how successful is the medication being that we're giving, and surgeons really need to know other things, kind of the anatomic relationship, the true strength of contractions, what part of the esophagus is functioning, which parts are not. And medical gastroenterologists, even if they're the most brilliant motility interpreters, simply don't look at that kind of thing.
We all like challenging cases. We like to do those cases that have been done elsewhere or have been, let's say, turned away by others. What would be the pearls that you would convey to me in a way to avoid problems? What patients I should not be operating on, generically speaking?
Yeah. Well, I think one of the keys, I hate to sound like a broken record, but I think one of the keys is especially in those complex patients, ones with, and I would call those patients ones with atypical symptoms, one with conflicting test results. Maybe they have a weak lower esophageal sphincter, but their pH study was negative, might be an example. Used patients, ones that have had multiple surgeries before. The key is you have to test those patients. You have to throw every test that there is at those patients and look at absolutely everything before you get into it. Those patients, we get endoscopy, upper GI studies, 24 pH impedance testing, high-resolution manometry, gastric emptying studies often, really to get a complete picture of what's going on in that patient, so you have in your mind, I know what's wrong, I know what's going on, I know that this herniated, it's slipped, it's 2 centimeters above the GE junction, and that's why it's not working for this patient.
I like the fact that you touch on the preoperative workup. And there are a lot of controversies, as you know. Some like to do their endoscopies, others would just rely on manometry. They may dismiss this, may dismiss that. In your practice, is it a one fit for all, or is it case by case? Let's talk, for example, about straightforward, let's call it straightforward condition, GERD, reflux, acid reflux disease. How do you tackle those patients preoperatively?
We do, on rare occasions, we won't get one of the tests. Big paraesophageal hernias, giant paraesophageal hernia, we don't typically get a pH test. They're often negative because the stomach's upside down, etc. But by and large, for a routine case, we get pH testing. Even if we know they have reflux, they've had some esophagitis, but I like to know how bad it is, because I treat a patient with a Demeester score of 60 different than I treat a patient with a Demeester score of 20. Motility, to look at the function, and we still tailor our fundoplication. So if somebody has really bad motility, tend to do a partial fundoplication, toupee, and an endoscopy, just to make sure that there's not pre-malignant changes or something that you don't want to commit them to a surgery because they may have a bigger problem brewing.
When you choose those patients and you move forward with surgery, do you have one setting in the operating room, or let's say, for example, positioning of the patient? Mm-hmm. Do you like to be on the right side, sometimes in between the legs, or how is it for you? How is it structured?
Yeah, because I'm quite tall, I found out a long time, I was taught to operate in the French position between the legs, but I find for the comfort of my assistants, I had to bend over quite a bit standing between the legs. So I tend to operate on the left side of the table. It's a little bit unusual, but I can do it on the right side or between the legs or whatever. That's just where I find physically more comfortable. But use 5mm ports preferentially, not larger ports except for the camera, 10mm for the camera. That's a little bit unusual. I think a lot of people still use 12 ports to do it, and a few idiosyncratic things like that. I don't think that's as important as kind of how you handle the anatomy and exposure and things like that is probably the more critical element.
To learn more from you, could you take us through a typical case, just in a nutshell, or bullet points, the key elements of, let's say, a hiatal hernia with Nissen fundoplication?
Sure. So as I say, I actually split the legs, and I put my camera. I usually operate with just one other person, a resident or a fellow or whatever. Put them in between the legs. They're comfortable. I like my camera person to be very comfortable, so I get steady imagery. Use a 45-degree scope routinely. Elevate the liver. We'll see if the hernia will reduce, gently see if it'll reduce. If it does, I'll divide the hepatogastric ligament following the caudate lobe. I think a technical point, I take it very, very high, all the way up to the left hepatic vein, so that the right cruce is really free to swing medially. I find that reduces tension a little bit. Practice a no-touch technique on the crura, and really hammer home always. The fellows and residents get tired of hearing me say it, not to disturb the peritoneal covering on the crura, because it's such a fragile structure and certainly the weak point of this surgery. circumferentially dissect that quite far distally, reduce the distal esophagus. I'll dissect as far as I need to, all the way up to the pulmonary vein to get a nice length of intra-abdominal esophagus. Once again, not touching the crura hardly at all and keeping the peritoneum intact on it. Watch out for the vaguses, although I'm not a big vagus worshiper. I don't think they're probably as critical as we have been taught that they are. Once I've completely dissected that out, and I do a lot of the posterior dissection from the right side, looking underneath with a 45-degree scope and clear off the back wall of the stomach.
Right side of the patient.
Yeah, from right side of the patient to the left side of the patient. Mobilize the short gastrics. I try to take as few as possible. I think I have a suspicion that some of the early satiety and bloating and things like that is related to devascularizing the greater curvature.
Do you have where do you exactly start if you have a particular area? Where do you start dividing the short gastrics?
Typically, I'll go to the southern pole of the spleen and straight across. My partner Bernard Delamon has a Delamon lipoma that he says is consistently about that level as well. Mobilize the greater curvature and do that by progressively rolling the stomach up so I can access the posterior pancreatic attachments. And then once that's done, do a shoe shine maneuver, pull it through. I do a short gastric to short gastric apposition. I found that that's easier to teach to the residents rather than the way I was taught by Tom DeMeester of a anterior wall to posterior wall, 9 o'clock suture line. And then close the hiatus. Large hiatal hernias, I'll use pledgeted horizontal mattress sutures, and smaller ones I'll use interrupted or figure of 8 Ethibond sutures. Close it posteriorly almost always, occasionally a stitch anteriorly. And then I put quite a few sutures in. I do a posterior gastropexy to the closed crus. I put 2 sutures on the inside of the wrap at the 3 and 9 o'clock position to kind of fuse the wrap to the wall of the esophagus to create a little adhesion. Always use a bougie. I use a large, either a 56 or a 60 bougie.
What time precisely?
So I close the hiatus first. I don't really need a bougie to close it. I leave just a small gap, and visually that's usually okay. On rare occasions I have to pop a stitch out and replace it. Do my shoe shine maneuver, posterior gastropexy suture, and then I pass the bougie at that point before I do any of the Nissen sutures. And I usually do about a 2 centimeter fundoplication. It's usually 3 sutures placed 5 millimeters away from each other, and I do take a little bite of the esophagus with each of those.
What's your take on one of the most controversial topics, mesh on the hiatus?
Yeah, I still use a biologic mesh for paraesophageal hernias. I don't use mesh routinely on a normal small type 1 hiatal hernia. I don't use it. We kind of know from our experience that the biologic meshes help in the early phase, the first few years, but probably after 5 years they go away and aren't that much of an aid. Like everybody else, I don't really know the answer to that. I've dug enough meshes out of people's esophagus over the years, and I'm a little bit gun shy from putting plastic mesh in there, although I strongly suspect that if your main goal was to keep that hiatal hernia from recurring, probably a piece of plastic mesh would be the ideal situation, but it's a balancing act to try to prevent those erosions.
Maybe another question that comes a lot, the releases on the right, on the left, to allow for a nice crural repair. What's your take on that? And if you have any?
Yeah, I do relaxing incisions fairly. Probably 3-4% of the time, I would say, for large defects, redo cases in particular because of the fibrosis of the tissue. I tend to do it on the left side, so I go quite away, 4 or 5 centimeters away, and roll the spleen down, do a nice radial incision, do my closure, and then I'll put a piece of Gore-Tex or double-faced mesh of some sort to reconstruct the diaphragm. I think it's a nice technique, certainly proven in inguinal hernias over the years to kind of minimize the tension on those patients.
So you prefer the left side?
I prefer the
right?
left over the right. Yeah, it's just easier to position the mesh afterwards and really effectively close that hole, and then you just let the spleen go back against it, and it's kind of hidden from sight.
And when you do that, what type of mesh do you use on the left?
Either a Gore-Tex or a double-faced Periotex, something like that, permanent mesh, of course. Tension minimization, also am a strong believer that you need collis, the ability, you have to know how to do a collis. I do it a little bit different. I do a transthoracic collis. So I need to do a lengthening procedure. I put a 45 bougie down. I do, in the fourth intercostal space, put a standard laparoscopic trocar, insufflate to 8 millimeters of mercury of CO2, so it collapses the left lung. Do thoracoscopy, make sure there's no adhesions, straight shot to the mediastinal pleura, and then I'll transilluminate, looking laparoscopically, transilluminate, hold the trocar still, take it out, slip a stapler in, make a little nick in the pleura, put it in the peritoneal cavity, and feed the esophagus, and a single firing gives you a nice added length of the esophagus.
From what you're saying, I think then my understanding is that you prepare every patient for like a chest incision and an abdominal incision. Or is it
so I have a funny philosophy about that. So I do prep quite a few patients. Their left axilla kind of into the field, because my philosophy is if you prep them and are ready to do a collis, you don't have to do it. If you don't prep them, forget to prep them, sure enough, you're it's the short esophagus. Now I have to cut the drape and re-prep and do that. So you're right. I'm fairly liberal. I don't do every patient. Some are clear that they don't have a short esophagus, but anybody at risk, we'll prep them just in case we need to do a collis.
And then, in your experience, what's the allowed length, or what's the acceptable length of intra-abdominal esophagus? 2-3 centimeters?
2.5. Usually like to get at least 2.5, kind of no undue tension.
And how do you finish your case? You do PECSI, like some like to do? Do you leave drains?
Never. Giant hiatal hernias, paraesophageal hernias, I'll put a drain in the mediastinum, just because you can get fulled with an air fluid level in the mediastinum, but a standard Nissen, I would never leave a drain. Don't do a gastropexy unless they have a hypermobile stomach, and I really think it's going to do a bascule or something.
Do you scope the patients when you're done?
Always scope at the end.
Excellent. This is before you close.
Before we close, yes.
And then patients stay one night? Maybe
we have an outpatient program for standard Nissens, so they go home the same day, and if they have any nausea or any things, they'll spend the night. Paraesophageal will spend the night.
Any special diet?
We put them on a pureed diet for the first 2 weeks.
And then they go back to anything they would like to.
Mm-hmm.
Excellent. Any pearls for let's say surgeons like me who would like to dare and do more of those revisions and complicated cases?
I guess the two pearls I would offer is don't operate on crazy patients. Stay away from them, at least in your early. When you get old and gray-haired like me, you can tolerate some crazy patients. And I think a real serious one is that if you operate on these patients, if you choose to operate on them, they really become your patient, and not to send patients that don't do well back to the gastroenterologist that sent them in the first place, because that gives them a false impression of the value of the surgery. So I tell younger surgeons that want to build a practice, only send the ones that do fantastic back to the referring doctor,
Okay.
and keep the rest for yourself.
Well taken points. Well, thank you, Dr. Swanstrom, for accepting this invitation. This was once again was the Trailblazers for Foregut Surgery here at Sages. It's been a pleasure. Thank you so
Great.
much.
Thanks so much.
Thank you.
Great.